Hello, we're going to go ahead and get started. Um, Tonight we're going to be focusing on general anesthesia and emergency situations from chapters 14 and 15. Now, we've already spent weeks learning how medications affect the body, how those changes impact our environment in the operating room. Tonight is really about connecting those concepts and strengthening your confidence before this week's quiz and, of course, the final exam. Now, I want to stress that as CSTs, we are not administering anesthesia, but it's so important for us to understand how anesthesia medications affect the patient and how that will help us or helps us anticipate what's happening during surgery and respond as a part of the team. As we move through tonight's session, I want us to be understanding what those medications are doing to the patient and why it really matters in the operating room. So we get into our quote of the week. Success is no accident. It's hard work, perseverance, learning, studying, and most of all, love what you're doing or learning to do. I thought this was especially fitting for week 10, right? None of you got here by accident. You've spent the last several weeks learning complex concepts, pushing through challenges, and continuing to show up when the material felt difficult. I want you to think back for a moment. What topic in this course took the most effort for you to understand? Maybe it was anesthesia, drug classifications, emergency medicine, pharmacokinetics, whatever it was. The fact that you understand it now is evidence of growth. Learning isn't about getting everything right the first time. It's about building knowledge one step at a time. As we move through tonight's live session, remember that the goal is not perfection. The goal is confidence, critical thinking, being able to apply what you've learned. So let's revisit one concept from last week, just one. Okay. How long is the onset of atropine? If a patient suddenly becomes bradycardic on the OR table, would you want the medication to work in 5 minutes or immediately? Right, immediately. That's why atropine has an almost immediate onset when administrated through IV. Think clinically, okay? Now, I did want to share with you guys this week's study guide. If you haven't already, please take a time to review it before attempting the quiz. For those of you that are here, let me copy it for you so that you have it, okay? The study guide is a resource, but it is catered to different concepts or many concepts that you may actually see on this week's quiz. It also kind of has different questions to kind of think through as you are gearing up for this week's quiz. On the same note, your final exam study guide is up on announcements, okay? I have it here for those of you that are like early to take the week 10, so you already have that cumulative study guide up on announcements for you. Okay, again, these are resources. Continue to look at your weekly study guides from your previous quizzes, look at your notes, videos, everything that you have so that you are comfortable and confident going into this cumulative exam. All right, now let's get into tonight's information. I want to talk to you all why all of this matters beyond just the quiz, beyond the final exam. As CSTs, we are a part of operating room safety net. While anesthesia is over there focusing on monitoring, focusing on managing the patient's physiological status, we are focused on kind of like maintaining that sterile field, supporting the surgeon, and anticipating what the team needs. One thing that you're going to hear me talk about often is anticipation. The best CSTs aren't just kind of like reacting to what's happening, we're already thinking ahead. That's where this idea of normal, abnormal action comes into play. The team is constantly assessing what's happening with our patient. When something changes, we recognize it, we understand what it means, and we respond appropriately. That doesn't mean that we are diagnosing the problem, but that we are just more aware of what's going on with anesthesia and the pharmacological aspect. Think about this for a moment. If anesthesia suddenly reports a change in the patient's condition during surgery, think about how that affects us as the team. We're going to be communicating, okay? We're trying to understand the language of anesthesia. It helps us to function more effectively as part of that team. Real story. We were doing a surgical procedure, and all of a sudden, our anesthesia was calm and collective. He touches the anesthesia screen and says, I have lost heart rhythm. Anesthesia screen back up. And it took me a second, like, what just happened? What is he talking about? And in that moment, we realized, okay, comes back again, whatever you're going to do, please do it now. Like, we need to close up and get the patient out. So it happens. But just like there's calm anesthesiologists, I have had some on the other spectrum as well. Okay, so kind of keep that in mind. Now, as we move through tonight's session, I want you to keep thinking about how these concepts connect to patient safety and teamwork, not just this quiz, not just the final exam. So we've got the 4 goals, 5 phases. We're going to start with the big picture. We're going to talk about general anesthesia, okay? We're talking about achieving 4 major goals. This is going to be important because I have seen these come up on this week's quiz. The patient needs to be unconscious, free from pain, unable to remember the procedure, and able to remain still during surgery. Those 4 goals work together to create the safest possible environment for both the patient and the surgical team. Now, if you look at the timeline on this particular slide, you'll see the journey of the patient takes through anesthesia. We start with pre-induction, where the patient is being prepared. Then comes induction, which is when the patient goes to sleep. Maintenance is where they stay asleep during the procedure. Emergence is waking up. And recovery is the continued stabilization after anesthesia. For the quiz, I want you to think of this as a timeline. Induction, going to sleep. Maintenance, staying asleep. Emergence, now they're trying to wake them up. If you can remember even just those 3, you'll be able to kind of work through many of the anesthesia questions confidently. So let me ask you this. If a patient starts moving during surgery, which of these phases would the anesthesia provider most likely be reassessing? Okay, we're looking at mobility and consciousness. But I want to make it a little bit more broader. Are we looking at pre-induction, induction, maintenance, emergency, or recovery? Right, maintenance. So some of these questions are, they may throw in outliers like unconsciousness, immobility, but I want you to kind of hone in on um, the phases. Like if you see the phases, then I want you to be thinking, okay, what exactly, where's this patient at? Okay. When you see the words during surgery, that means the procedure is going on. Okay. Now, one of the most important responsibilities during general anesthesia is maintaining the patient's airway. I want you to think about it this way. If the patient cannot move air, nothing else matters. Full stop. Oxygen has to reach the lungs for the patient to remain safe throughout the procedure. If you look at this particular slide, you'll see two common airways the chapter talks about. The first is the laryngeal mask airway, or what we say is the LMA. The LMA, it sits above the vocal cord and keeps the air open, keeps the airway open. This one is less invasive than a endotracheal tube, and it's often used for certain select procedures. The second is the ET, or the endotracheal tube. That one passes through the vocal cords and into the trachea. This provides a more secure airway, it allows controlled ventilation, and it helps protect against aspiration. So one thing that I've noticed that gets mixed up this week is the cricoid cartilage and the thyroid cartilage. If you remember one thing from this slide, remember that the Salic maneuver, or cricoid pressure, is applied to the cricoid cartilage, not the thyroid cartilage. That's a favorite exam point because the names do sound similar. Okay. Now, why would airway protection be especially important during a rapid sequence induction? So we're trying to get the patient to sleep fast. And there are no wrong answers. I just want to kind of have us all work through this together. What would happen if the airway was not protected? Think about the procedure cannot move forward because the airway are without a protective airway. Okay, exactly. Okay, let's say we're trying to get the patient to sleep fast, right? What might happen if stomach contents come back up before the airway is protected? Yes, aspiration. Okay. Now, if the stomach contents do come up, it can be very serious. Okay. Now that we reviewed how the airway is protected, let's look at what happens physiologically as anesthesia progresses and different medications that we use. So we have what's called the sleep switch. These are called induction agents, right? Their job is pretty straightforward. They help transition the patient from awake to unconsciousness. And they do it very quickly, usually within minutes. You've seen those videos where the person's like, I'm going to try to stay awake as long as possible, right? And you see anesthesia like, okay. And they count and they're doing their best, but I have never seen a person be able to win with that particular thing, okay? So if you look at the slide, you'll see three common examples. Propofol. This is probably the one you'll hear about the most. It's commonly used because it works fast and patients tend to wake up relatively quickly once it's stopped. You have etomidate. It's often selected when maintaining, let's say, cardiovascular stability. In other words, it's good for patients who cannot tolerate significant changes in blood pressure. And then we have ketamine, which is a little different. It creates what's called a dissociative state. The patient isn't experiencing their surroundings normally. They're not processing pain the way we typically would expect. But here's the takeaway that I want you guys to get from this particular slide. These medications help patients go to sleep, but they do not provide muscle relaxation. That is an important distinction because sometimes students assume that, like, you guys will see unconscious automatically means relaxed, but it doesn't. In anesthesia, those two are actually separate goals. Think of, think about it like this for a moment. If these medications make a patient unconscious but don't relax the muscles, why might additional medications be needed before placing that ET tube? Retrograde amnesia. Okay, that's a good one. What else? So think about this way. They are unconscious, but the muscle reflexes have not been relaxed. Think about the gag reflex. What would happen if the anesthesia provider was trying to intubate a patient who was, yes, unconscious, but their muscles were still able to show different reflexes? Think about the gag reflex. They won't be able to intubate because of the reflex. Exactly. Let's look at how the rest of um, anesthesia works in the operating room for us. Okay. Now, we have the sleep switch, but because they won't be able to really intubate them because of the reflexes, now we have to add the paralysis switch. Neuromuscular blockers are used to create skeletal muscle paralysis. This helps with procedures that require the patient to kind of be completely still and also make endotracheal intubation not only easier, but also safer. Here's the most important thing I want you to remember from what you're saying. Neuromuscular blockers do not make a patient unconscious. They do not relieve pain. They only stop the muscles from moving. That's why these medications are given after the patient has already received sedation or induction agents. So SUX is the most common depolarizing neuromuscular blocker. One thing that makes it unique is that it often causes brief, like, muscle twitching called fasciculations before, like, the paralysis actually occurs. If you see that in an exam question, I want you to think sucks, succinylcholine, okay? In other words, fasciculations or muscle twitch equals sucks. Now, we come on the other side, and you'll have medications like vecuronium. These are non-depolarizing neuromuscular blockers. These drugs block muscle contractions without causing those initial, like, twitching. Okay. So think about it like this. If a patient received a neuromuscular blocker but was not adequately sedated, we would be concerned with the patient could be conscious but not able to move, which is why anesthesia carefully coordinates these medications with induction anesthetic agents. There was a movie that was made, Awake, with I think Jessica Biel, where her fiance or whatever was on the table and could not move but was awake. Okay, granted it was Hollywood, but if you ever get the chance, that particular section in the movie kind of like brings it home. Okay, now I want to take a little bit time on this next one. This is one of the most important anesthesia emergencies you'll see on exams and be exposed to um, in the real OR. Malignant hypothermia, or MH. This is a kinetic condition or genetic condition that causes the body's muscles to abnormally to react abnormally to certain anesthesia medications. If you remember one trigger combination, remember this: succinylcholine plus volatile inhalation anesthetics. Those are the two major triggers associated with malignant hypothermia. But what happens first? One of the biggest exam traps, is fever. Okay, so hear me out. Most students think malignant hypothermia starts with a high temp. It does not. I have seen this concept in week 10, and we see malignant hypothermia, we think hyperthermia, we immediately go fever first. I'm letting you guys know now that is not the first sign. The earliest sign is usually a rapid rise in end-tidal CO2. So their CO2 starting to get higher. You may also see muscle rigidity, especially jaw rigidity. So if you see a question describing rising CO2 levels and muscle rigidity after anesthesia induction, I want you to start thinking malignant hypothermia. Don't wait for fever. Hyperthermia is often a late sign, not an early sign. By the time the temperature begins rising significantly, the crisis may already be well underway. Okay, so let's test it out. If you're in the operating room and anesthesia provider notices the patient's end-tidal CO2 is climbing ever so rapidly, even though ventilation has not changed, what anesthesia emergency should immediately come to mind? I've got one with the correct concept already. Anyone else? Are we all kind of in agreement with the malignant hyperthermia? Yes. Okay. Biggest thing on that is elevated CO2, end-tidal CO2. Fever comes later. Okay. I have seen concepts this week that bring that up. Now, once malignant hyperthermia is suspected, the team, we don't stop and debate, is this MH or is it not? We go into action. This is a true operating room emergency, and it requires rapid intervention because at this point now we're trying to save the patient's life. One way to remember the major treatment steps is the acronym HD STDI. HD STDI. Also, you guys can take screenshots just so you guys know. All right, so let's break it down. So we see it over here. We're going to hyperventilate that patient, 100%. These patients are producing massive amounts of carbon dioxide. So increasing oxygen and ventilation is extremely important. If you see a couple of drugs being presented and they're talking about MH, you're going to automatically think dantrolene. This is the antidote for malignant hyperthermia. We get into the S for sodium bicarbonate. It helps correct metabolic acidosis. Remember, we got to get their temperature down. So T is temperature control. Now we have cooling measures to help bring it down. D is diuretics. This is going to help protect the kidneys from damage caused by the muscle themselves breaking down. And then the last one down here you see is insulin, which may be used to help manage elevated potassium levels. For your quiz, I do not expect you to kind of like memorize in detail every single thing. What I do want you to remember is recognizing MH early. Stop the trigger agents. Give dantrolene. Begin supportive treatment immediately. So keep in mind that if malignant hyperthermia is suspected during surgery, it is important for the entire team, not just anesthesia, to understand that emergencies require all of us to be on the same page. It requires teamwork. Everyone has a role. The faster the team works together, the better the outcome is for the patient. Okay? Does that make sense? Because I have seen so many concepts on MH, from especially that high in tidal CO2 and fever a lot. Okay. Now, let's look at the three anesthesia emergencies that you will commonly see on the quiz or even your final. The good news is if you can recognize the key symptoms, you can usually figure out the correct intervention. First is a laryngospasm. Okay, this happens when the vocal cords suddenly just close. Now it's difficult or even impossible to move air through the airway. So the classic sign is what we call stridor, that high pitch, like crowing sound. The first thing anesthesia will usually try is positive pressure ventilation. If the spasm does not resolve, medication such as sucks may be needed. Then we have a bronchospasm, which is the next one. Unlike laryngospasm, the problem is not the vocal cords. The bronchi inside the lungs constrict, making it difficult to move air. And this one, you'll hear more of a wheezing. When you see wheezing, think narrowed airway, medication that helps open them, such as albuterol. And then we come down to anaphylaxis, a severe allergic reaction. I want you to remember that it's a sudden hypotension. Patients may also show other signs of an allergic response, but if a question describes a rapid drop in blood pressure after exposure to a medication or a latex, I want you to be thinking anaphylaxis. The primary treatment in this case is epinephrine. If you're struggling to tell these apart, I want you to focus on the key clue. Laryngospasm, stridor. Bronchospasm, wheezing. Anaphylaxis, hypotension. If you can identify the clues, you can usually kind of um, identify the emergency. Okay, so let's try one. If you suddenly hear a high-pitched crowing sound during ventilation, which emergency should come to mind first? Exactly, laryngospasms. Okay, so now let's talk about the code blue in the operating room. We get the cardiac arrest. When this happens, the entire team, we have to kind of work together quickly and efficiently. Everyone has a role, including us as the CST. If you look at the slide, you'll see some of the medications commonly associated with a cardiac arrest. Epinephrine, the most common drug, right? Um, Amiodarone may be used to treat certain life-threatening arrhythmias. Atropine may be used in situations involving severe bradycardia. For your quiz, I want you to recognize the medications most commonly associated with emergency cardiac events. Now let's talk about our role. Even during a code, we have important responsibilities. We may need to protect the sterile field. We may need to assist the surgeon, provide needed supplies quickly, or help prepare equipment that the team may need. If the procedure is open, maintaining organization, anticipating needs becomes even more important because things can become chaotic very quickly, trust me. Think about this for a moment. During a code, why is it important for us as CSTs to remain calm and organized, even when everyone else in the room is moving quickly? The reason I want you to think about this is because a calm, organized CST, we help support the surgeon and contribute to the team's ability to respond effectively. So let's get into a clinical scenario. Imagine you're in the operating room during an emergency trauma case. Rapid sequence induction has been performed. The anesthesia provider administers sucks. A short time later, the anesthesia provider reports the patient's jaw has become rigid, what we call masseter muscle rigidity. Whenever you see a scenario like this, I want you to start connecting the clues. We know that sucks is a trigger for MH. We know that muscle rigidity can be one of the early warning signs. So my first question for you is, what anesthesia emergency should immediately come to mind? That's correct, MH. Now let's take it one step further. If MH is suspected, what anesthetic agent should be discontinued immediately, right? So, sucks. Also, just for everyone else, you may see volatile inhalation anesthetics. So just keep in mind that's what they're talking about. Okay. Or you may even see triggers. Triggers, sucks, whatever inhalation agent that they provided. Okay. So, yes, correct. Now, finally, what medication should the team begin preparing? Think about the antidote. What is the antidote for what we suspect? Correct. Dantrolene. If you look at the monitor values on this particular slide, you'll notice additional clues. The heart rate is increasing, the end-tidal CO2 is climbing, and the temperature is beginning to rise. Taken together, those findings tell us that the patient's metabolism is accelerating, which is exactly what we'd expect with MH. Okay. Now, I want to spend a minute on a few concepts that commonly get mixed up on that cumulative exam. I call these the trap cards because the information is usually familiar. The challenge is recognizing exactly what the question is asking. Atropine versus adenosine. If the patient has a slow heart rate, think atropine. If the patient has, let's say, a supraventricular tachycardia or a SVT, think adenosine. The key is recognizing whether the rhythm is too slow or too fast. Another trap, epinephrine versus ephedrine. Now, when you hear cardiac arrest, anaphylaxis, or a major emergency, think epinephrine. When you hear anesthesia-related hypotension or blood pressure support, I want you to think of ephedrine, okay? Now, make sure that, okay. Then we get to weight conversion. If a patient is given in pounds, your first step is usually to convert it to kilograms. In the operating room, we do kilograms. Okay, remember pounds divided by 2.2 equals kilograms. When you see a pharmacology question, pause. Ask yourself, is this testing a drug indication? Is this testing recognition or a clinical situation, or is it testing a calculation? Sometimes the simple question helps to kind of narrow the answer immediately. All right, so is the end tidal CO2 measured by pulmonary functional test? No, but great question. It's not typically measured by the PFT. Um, it's usually measured by capnography, and then it reflects the amount of carbon dioxide exhaled at the end of expiration. But in the OR, our anesthesiologists, what they'll do is they'll confirm endotracheal tube placement, and then they're watching the monitor. Um, they're looking at the patency of the patient's airway, and then they try to identify different problems like hypoventilation, apnea, or circuit, like let's say something just got disconnected. I want you to think of the end-tidal CO2 as how much CO2 is the patient blowing off right now. When you talk about the PFTs, you're looking at how well the lungs are functioning overall. So we're really looking at how much is actually coming off. Excellent question. You're welcome. Okay. There are also 10 concepts I really want you guys to master. Okay. When, and you guys can take a screenshot of this, y'all. These are not new topics. You've seen most of these multiple times. What makes them important is that they tend to show up repeatedly in quizzes like this week, and you may definitely see it again next week. They also come up in clinical discussions and honestly in real world practice. Now, let's see how we can identify them together. We'll start here. Salmic maneuver equals cricoid pressure. Okay. MH is most commonly triggered by sucks and volatile anesthetics. So if you don't see succinylcholine, you may see volatile anesthetics, or they may even say the trigger. Okay. The antidote for MH is dantrolene. The earliest signs of malignant hypothermia is often a rise in end-tidal CO2. Again, one of the earliest signs of anaphylaxis may be sudden hypotension. One thing that the chapter does bring up and that you may see is that propofol is the induction agent associated with soy and egg considerations. Versed is associated with anxiety reduction, or we usually give it for amnesia. That's usually what they'll give first. Okay. Bear block from last week uses lidocaine and a double cuff tourniquet. I will repeat that. A bear block uses lidocaine and a double cuff tourniquet. And epinephrine is strongly associated with cardiac arrest and severe emergencies. If I was kind of like studying for this final exam, this cumulative, let's say this evening, I would focus on making these associations. When you hear MH, I'll be already thinking dantrolene. When you hear CVT, I want you to be thinking adenosine. When you hear stridor, I would probably be thinking of a laryngospasm. Um, the exam or even this week's quiz wants to make sure that we can kind of recognize the patterns more than kind of looking at it as isolated facts. As you look at this list, I want you to ask yourself this question. Which of these concepts could I confidently teach to a classmate? And which one would I want to spend maybe another 10, 15 minutes kind of reviewing before the quiz or even next week's cumulative exam? That answer is going to tell you exactly where to kind of focus your study time this particular week. Okay. And we're at that time again. Now, even though I will not have you next module, your experience still matters. And your feedback really does help strengthen this course. Okay. Let me get the link in the chat. Now, you live the module, you've seen what works, you've experienced where things could really be clearer. Sharing that insight does allow us to kind of just really continue improving how future students learn these concepts. Okay, so I'll give you guys 5 minutes. I want you to answer honestly. Let your voice be a part of shaping the program for the next group of learners. Again, this is anonymous. We do not know who said what, when, where, and how. We only know if you were able to complete it or not. Okay, so I truly believe that closed mouths do not get fed, and I want y'all all to eat. Like, I want to know exactly what works, what didn't, what can be improved, or if things are good, leave this, keep that, move that. All right, so you'll have 5 minutes, and I will be back once the timer is done. All right. Now, for those of you who are watching the archive, during the review session, we discussed several emergency patterns such as MH, respiratory emergencies, and cardiac arrest. What early sign helps the ST team recognize the problem? Also, one theme throughout this entire live session was our understanding of why. How understanding the reasoning behind helps us make safer clinical decisions. Explain that. Now, before we finish tonight, I do want to take a moment and think about how far we've come over the last 10 weeks. You've spent weeks learning about medications, anesthesia, emergency situations, and how all of those pieces connect to patient care in the OR. And if you've noticed a theme throughout tonight's live session, pharmacology isn't about kind of looking at different drugs, right? Names. It's about understanding what is happening with our patients. As CSTs, we are constantly observing, we're anticipating, we're supporting our team. That's exactly the type of thinking that this week's quiz and next week's cumulative exam questions are going to be designed to assess. So when you sit down for this week's quiz, don't rush. Read the question carefully. Look for the clinical clues. Ask yourself, what is actually happening to our patient? Once you understand the situation, the answer often becomes much clearer. Okay. I know some of this material can be challenging, but you've put in the work. Okay. You've come to the sessions, you've watched the archive for those of you that are watching, you've completed assignments, you've participated in discussions, you've contributed to just really building your knowledge week after week. So trust what you've learned, trust your preparation, and most importantly, trust yourselves. I can say I am incredibly proud of the effort you put into this course, but more important than that, I want you to be proud of what you've put into this course. With that, what questions do you have for me? Okay. Now, if something does come up, let me know. With that, I hope you guys have a wonderful evening. Thank you for spending your time with me this evening, and I do look forward to seeing everyone who can attend tomorrow's live session. With that, good night, everybody.